Hello everyone, welcome to Veterinary Pharmacology 322. This presentation we will be discussing about the drugs acting on the urinary system and fluid therapy. But first, let us briefly discuss the basic physiology of a nephron within a kidney. The figure shows the different parts of the nephron. The nephron is the basic structural and functional unit of the kidneys that regulates water and soluble substances in the blood by filtering the blood, reabsorbing what is needed, and excreting the rest as urine. The glomerulus is a capillary tuft that receives its blood supply from an afferent arteriole of the renal circulation. It is where the fluid and solutes are filtered out of the blood and into the space made by Bowman's capsule. The proximal and distal tubules, loop of Henle, and the collecting ducts are the sites for the absorption of water and ions. And now, we will be discussing about the drugs acting on the urinary system. First are the diuretics. Diuretics are drugs which promote urine formation and its secretion, augmenting sodium and water loss from the body. Its primary clinical use in veterinary medicine is in the prevention and treatment of generalized edema or severe local edema. All diuretics act directly on renal tubular epithelia at specific sites in the nephron. The table shows the site of actions of diuretics. In the proximal convoluted tubule, 65% of the filtered sodium and water is reabsorbed from this segment. In the descending loop of Henle, sodium and chloride ions are not reabsorbed but become progressively concentrated in luminal fluid as water is osmotically removed into the hypertonic medullary interstitium. The thick portion of the ascending loop of Henle, 25% of the filtered sodium is reabsorbed in this segment. It is the site of action of the most potent diuretic drugs. The early distal convoluted tubule, 10% of filtered sodium is reabsorbed in this segment. In the late distal tubule and collecting duct, 4% of filtered sodium is actively reabsorbed in this part of the nephron. Aldosterone acts on this segment to increase luminal sodium channels, resulting in increased sodium absorption and potassium excretion. Water is reabsorbed only if antidiuretic hormone is present. Diuretics are classified based on their mode of actions. First are the osmotic diuretics. Osmotic diuretics are filtered at the glomerulus but are poorly reabsorbed from the lumen of the nephron. The presence of these unabsorbed solutes in the proximal tubule causes decreased reabsorption of water, resulting in a large volume of urine. There is a small increase in sodium and chloride excretion. Osmotic diuretics are used for the treatment of poisoning in dogs and cats, oliguric renal failure in dogs and cats, and increase in intraocular pressure of acute glaucoma in dogs and cats. Also, these are used for the treatment of cerebral edema in large and small animals. The commonly used osmotic diuretic, the mannitol, is used to induce forced diuresis, adjunct to furosemide therapy, reduce intraocular pressure, and prevent the hypovolemic shock commonly observed in cerebral edema. Its adverse effects: toxicity is rare, but fluid and electrolyte balance and urine output should be monitored, especially in the treatment of oliguric renal failure. In mannitol should not be used in generalized edema or acute pulmonary edema. Mannitol solutions are administered by slow intravenous infusions over 15 to 30 minutes in all species. Doses may be repeated every 6 to 8 hours. Mannitol solutions causes increase in renal medullary blood flow via a prostaglandin-mediated mechanism. The next classification of osmotic diuretics based on their mode of action is the carbonic anhydrase inhibitors. The carbonic anhydrase inhibitors are reversible inhibitors of carbonic anhydrase, predominantly in the proximal convoluted tubules. causing a reduction in hydrogen ions available for sodium and hydrogen exchange. It reduces intraocular pressure in glaucoma by decreasing the production of aqueous humor. Its therapeutic uses include reduce the rate of aqueous humor, formation in the treatment of glaucoma, used as adjuncts in the treatment of metabolic alkalosis, and their diuretic action is weak and they are seldom used for this purpose now. The adverse effect of it is that it is contraindicated in the presence of liver disease. The commonly used CA inhibitors are acetazolamide. Acetazolamide is given 5 to 8 mg per kilogram per os every 8 to 12 hours. In acute cases, a single intravenous dose of acetazolamide is given followed by an oral dosage regimen. Dichlorpenamide, this is given 2 to 4 mg per kilogram per os every 8 to 12 hours. Metazolamide is given 2 to 4 mg per kilogram per os every 8 to 12 hours. It is the drug of choice because it has fewer adverse effects. Dorzolamide is a topical carbonic anhydrase inhibitor, must be applied every 8 hours, and it is formulated with an acid pH and can sting to improve corneal penetration. It is more likely to cause a contact irritation with periocular alopecia. Next classification of diuretics based on their mode of action is the thiazide diuretics. Thiazide diuretics, they block sodium chloride co-transport in the early part of distal tubule. Sodium, chloride, magnesium, and potassium ion excretion are increased. Calcium ion excretion is decreased and may induce hyperglycemia and glycosuria in diabetic or pre-diabetic states by inhibiting the conversion of proinsulin to insulin. Thiazide diuretics are effective in reducing urine output in nephrogenic diabetes insipidus in dogs. The chlorothiazide and hydrochlorothiazide are useful for long-term diuretic therapy in dogs and cats as adjuncts to cardiac drugs in the treatment of congestive heart failure. Hydrochlorothiazide and trichlormethiazide are used in the treatment of other edema in cattle. Hydrochlorothiazide reduces urinary calcium ion excretion and is used for the treatment of calcium oxalate uroliths in dogs. The adverse effects of thiazide diuretics include hypokalemia and hypochloremia. Hypokalemia and hypochloremia may develop with high or prolonged doses. Hyperglycemia may also occur and may aggravate pre-existing diabetes mellitus. Chlorothiazide is administered orally twice a day in dogs and cats. A diuretic response occurs in 2 to 3 hours and lasts 6 to 12 hours. Hydrochlorothiazide is administered orally twice a day in dogs and cats. A diuretic response occurs in 2 to 3 hours and lasts 6 to 12 hours. The next classification of diuretics based on their mode of action are the acidifying salts. Acidifying salts like ammonium chloride lower the pH of ECF and urine. The liver converts ammonium chloride to urea, hydrogen, and chloride. Hydrogen ion is buffered by HCO3 in plasma and this leads to acidosis. The increased chloride load to the kidney produces urinary loss of sodium and chloride and a mild diuresis. Ammonium chloride are used for urinary acidification to dissolve uroliths or to prevent their formation. It is also used to enhance the renal excretion of ionizable drugs or poisons by iron trapping in the urine. The adverse effects of acidifying salts includes severe uncompensated acidosis may result if renal function is impaired. Nausea and gastric irritation may occur with oral dosing, and it is contraindicated in the presence of decreased liver function. The ammonium chloride is administered orally 2 to 3 times a day or added to the diet in dogs and cats.
Aldosterone antagonists. Aldosterone promotes sodium reabsorption and potassium excretion. It activates the sodium channels to open, causing rapid reabsorption of water in the tubular cells from where sodium enters into blood in exchange of potassium. Too much aldosterone can cause high blood pressure and a buildup of fluid in body tissues. Aldosterone antagonists prevent the action of aldosterone combining with a sodium channel receptor, resulting non-opening of the channel, leading to failure of reabsorption of sodium from the lumen of collecting ducts, causing diuresis accompanied by significant natriuresis. Examples of aldosterone antagonists are spironolactone, eplerenone, and canrenone. Spironolactone is a potassium-sparing diuretic that can be used as an adjunct therapy for chronic refractory heart failure, although it appears to have a little diuretic effect in normal dogs. It must be used cautiously in patients receiving an ACEI or potassium supplement and is absolutely contraindicated in hyperkalemic patients. Mercurial diuretics. This acts through formation of mercuric ions in the tubular epithelial cells. These ions combine with cysteine present in thiol-containing enzymes associated with ion transport system mechanisms operating in proximal portion of distal tubules, preventing NAR, potassium, and chlorine reabsorption from the tubule lumen, causing diuresis. These are no longer recommended due to chances of renal damage. Examples of mercurial diuretics are mersalil, merbafen, and mercumatilin. Potassium-sparing diuretics. These act by blocking luminal of sodium channels, prevent sodium reabsorption in the collecting tubules, and decreasing potassium excretion. Examples of potassium-sparing diuretics are amiloride and triamterene. Amiloride inhibits sodium-potassium ATPase in distal convoluted tubules and prevents reabsorption of sodium in exchange of potassium. Sodium is eliminated accompanied with water diuresis. Triamterene stabilizes membrane potentials in luminal phase in DCT and prevents exchange of sodium and potassium, causing sodium elimination and water diuresis. Loop diuretics. These diuretics reduce aldosterone secretion and plasma volume. Potassium salts are to be supplemented along with loop diuretics to compensate hypokalemia. It is also advisable to give potassium-sparing diuretics along with loop diuretics. Furosemide also causes hyperuremia and gout by decreasing renal excretion of uric acid. Examples of loop diuretics are furosemide, bumetanide, and pyretanide. Furosemide is a loop diuretic used almost exclusively for animals with cardiogenic edema or effusion.
Theophylline, aminophylline, and caffeine. These are xanthine diuretics. These cause diuresis indirectly, improving the cardiovascular hemodynamics, cardiac stimulation, increased cardiac output, increased renal blood flow, and increased GFR. In addition, these also inhibit the action of ADH in the collecting tubules. Theophylline is the most potent. These are the clinical uses of diuretics. To relieve edema of nephritic, hepatic, or cardiac origin, and ascites of nephritic or hepatic origin, in oliguria due to renal disease, to promote renal excretion of systemic toxicants, and in post-operative flush of urethra after removal of renal or urethral calculi. The table shows the doses and administration of diuretic drugs in animals. For acetazolamide, 2 mg per kilogram orally once in a day, or 0.5 to 1 mg per kilogram IM once in a day. For chlorothiazide, 10 to 15 mg per kilogram orally twice a day, or 1 mg per kilogram IM or IV once in a day. For furosemide, 5 to 10 mg per kilogram IM once or twice a day, or 2 to 6 mg per kilogram IV once a day. For hydrochlorothiazide, 0.5 to 1 mg per kilogram orally twice a day. For mannitol, 250 to 500 mg for dogs, 5 to 10% solution by slow IV. For spironolactone, 2.5 to 5 mg per kilogram for dog orally twice a day. Urinary alkalizers are basic agents for alkalinization of urine. Alkalinization of urine promotes antibacterial action of certain antibiotics, excretion of acidic drugs, and increasing the solubility and reducing the risk of sulfonamide renal toxicity, especially in carnivores. Urinary alkalizers also increase urinary excretion of salicylates, basic salts such as sodium bicarbonate, and those get converted to bicarbonate such as sodium acetate or sodium citrate are commonly used as urinary alkalizers. For sodium bicarbonate, 0.5 to 1 gram thrice daily with large intake of water for dogs. Urinary acidifiers are drugs which cause acidification of urine. They help in increased excretion of basic drugs and enhance the antibacterial action of urinary antiseptics like hexamine and certain antibiotics like penicillins and tetracyclines. Sodium acid phosphate can be used as urinary acidifiers for 0.2 to 0.3 grams or ascorbic acid for 250 to 500 milligram or methionine for 30 milligram or chlorothamine for 60 to 90 milligram thrice daily orally. Ammonium chloride may also be used as an urinary acidifier as it causes acid diuresis.
Urinary antiseptics are drugs which exert antiseptic or antibacterial action in urinary tract. Sulfonamides, contromexazole, nitrofurantoin, and antibiotics like streptomycin, gentamicin, oxytetracycline, or carbapenicillin are commonly used in acute urinary tract infections. In chronic urinary tract infections, hexamine, mandelic acid, nitrofurantoin, and alidixic acid are used. Hexamine in acidic medium is broken into ammonia and formaldehyde, which exerts antiseptic action. Urinary acidifiers enhance the antibacterial activity of hexamine and hence are used prior to hexamine. The following is the mechanism of action of some urinary antiseptics. First is the sulfonamides. The sulfonamides inhibit multiplication of bacteria by acting as competitive inhibitors of p-aminobenzoic acid in the folic and metabolism cycle. Most sulfonamides are readily absorbed orally. Next is the cotrimoxazole. It works by stopping the growth of bacteria. The nitrofurantoin is activated inside the bacteria by reduction via the flavoprotein nitrofurantoin reductase to unstable metabolites, which disrupt ribosomal RNA, DNA, and other intracellular components. It is bactericidal, especially to bacteria present in acid urine. The streptomycin is a member of family of antibiotics that work by interrupting the function of bacteria cell ribosomes. Gentamicin, an aminoglycoside antibiotic, is bactericidal. Gentamicin passes through the gram-negative membrane in an oxygen-dependent active transport. As oxygen is required, this is why aminoglycosides are not effective in anaerobic bacteria. Oxytetracycline inhibits cell growth by inhibiting translation. It binds to the 30S ribosomal subunit and prevents the amino acyl tRNA from binding to the A site of the ribosome. The binding is reversible in nature. Carbapenicillin exerts its antibacterial activity by interference with final cell wall synthesis of susceptible bacteria. Then we have the fluid and electrolyte therapy. The fluid therapy consists of administration of isotonic fluids to correct body's fluid imbalance. It is advocated in hemorrhages, vascular shock, anemia, hemolysis, failure of blood clotting mechanisms, and to provide specific antibodies against infections. The different fluids used are the whole blood, blood plasma, blood serum, and plasma volume expanders or extenders. The electrolyte therapy is administration of special electrolyte solutions to correct hypovolemia, overhydration, electrolyte imbalance, and metabolic acidosis or alkalosis. The following is a different electrolyte solution used in specific solutions. 1.3% sodium bicarbonate in saline or 5% dextrose electrolyte solution is used for mild acidosis. 5% sodium bicarbonate or Ranger's lactate for severe acidosis. Ranger's lactate plus sodium bicarbonate at 5 grams per liter for acidosis and hypokalemia. Potassium acidifying solution for alkalosis and hypokalemia. And balanced electrolyte solution for acidosis, alkalosis, loss of electrolytes, and dehydration.